I'm Mike Govoni, and for the last 15 years, I've been in recovery from addiction and on the deepest quest to find healing, to experience my own unique wholeness beyond the story of what happened to me. By taking an integrative, holistic approach to experience transformation, I bring you the Healing Beyond Recovery podcast, a show dedicated to people in recovery who are looking to experience deeper healing and transformation. Hello, everyone. My name is Mike Govoni, and welcome to the Healing Beyond Recovery podcast. If this is your first time tuning into the show, welcome. To share a little bit about myself, I've had to overcome some of life's greatest challenges, including childhood trauma, addiction, and chronic illness. After experiencing deeper healing, it's my passion and purpose to help other people in the recovery community like you experience the same. Before we jump into today's episode, I want to let you know about my passion and purpose in the form of service, and that's my work as an integrative recovery coach. I offer my service in the form of a one-on-one coaching program called Healing Beyond Recovery. You can learn more about me and my services on my webpage at www.mikegovoni.com. There you can also sign up to receive my bi-weekly vlog by entering your email address. Now, for the important stuff. On today's episode, we are speaking with Dr. Daniel Sumrok. Dr. Daniel Sumrok is the medical director of the Integrative Health Center in Nashville, Tennessee. Dr. Sumrok brings exceptional achievement and thought leadership in the field of trauma-informed treatment. Board certified in both family medicine and addiction medicine, he is currently president of the Tennessee Society of Addiction Medicine. Also, he is a member of the faculty of the University of Tennessee Medical School. It's my great pleasure and honor to welcome Dr. Daniel Sumrok to the show. Dr. Sumrok, welcome to the Healing Beyond Recovery podcast. I'm so excited to have you. And let's begin by asking you, as a medical physician who's board certified both in family medicine and addiction medicine, what inspired you to take an interest in trauma and specifically a trauma-informed treatment for addiction?
Well, I think that's a great question. Thank you, Mike. I'm flattered to be asked to talk with you. I will tell you that I was, before I went to medical school, I was on active duty in the U.S. Navy from 1971 to 1976. I got out at the end of the Vietnam War and went to physician assistant training. And after PA school, I applied and was accepted into medical school at Marshall University. And I was a first-year medical student. I was a single parent because I had been a pretty crappy spouse. And I was raising a 1-year-old living on the GI Bill, which was about $300 a month at that time. And when the end of the first year came, and I had those 3 months off between the first and second year of medical school, the VA offered me the opportunity to go in there and do some research. I wasn't a serious researcher. I didn't really have a topic that I was particularly interested in, and I certainly wasn't ready to cop to having any trauma myself because I was going back on active duty. And the very last thing you wanted to mention it on active duty is trauma. So I spent a couple of months just hanging out with my buddies, other veterans at the vet center. Reagan had started the storefront vet centers in 1980. PTSD was a brand new diagnosis. Nobody really knew what that meant. I certainly didn't, and most physicians didn't, and I would venture that today most don't. So I decided I would study PTSD, try to write a paper describing it so that other medical officers would be able to recognize a case when they saw it. So 2 months into it, I had pretty much wasted my time and hung out with my buddies and ran around town drinking too much and playing ball and having fun like any college student would, and feeding my son from that little stipend. So one day in group therapy, I realized you haven't done any meaningful work and you better get busy. And so I took out a piece of paper and a pen and I looked around the group, the circle that I was in, and I thought, as veterans, what do we have in common? And I wrote down problems with the law, substance use disorders, difficulty sleeping, difficulty with concentration, depression, thoughts of suicide, and chronic pain. And then I wrote a paper and I called it The Public Health Legacy of Vietnam in Appalachian Combat Vets. And lo and behold, it got published for a first year medical student. And that was, I got a little bit of recognition at the medical school for that. And because it was published in a medical journal, the consequence is that almost nobody read it, right? Because it's a very limited audience in a medical journal. When I then thought about trauma, I thought the symptoms were social disruption, substance use, difficulty with sleep, depression, trouble concentrating. So that's kind of the way I've always thought about post-traumatic stress disorder. When I was about 50, I quit delivering babies. I was originally an obstetrician trained in OB out in Phoenix and a family doc, and I was out in a rural place. And at 50, I decided I was too old to stay up in labor anymore all night. And so I also realized that my county at that time was awash with methamphetamine, alcohol, and hydrocodone. And so I thought I would see if I could find some training about that. I was in Honduras with another old Army buddy, and I was telling him this story, and he said, in the special forces kind of a way, he said, well, why the hell don't you do something about it? And I thought, gee, what do I do? So I came back to the States, and I found a training program up in Boston at the Harvard bunch up there. At that time there were no fellowships, so they did a year-long series of seminars where you could go for long weekends and get familiar with addictions topics. The more I looked at it, the more substance use disorder looked like it was a consequence of trauma. And then I became familiar with Dr. Folletti's ACE study. That was about 18 years after I had written that study about PTSD. And it just absolutely all came together for me there. So I started, meeting like-minded physicians and nurses and therapists who understood about trauma and its consequences. And then I got an extraordinary opportunity. I went down to the medical school about 2010, and they hired me to start what I called the Center for Addiction Sciences. And then I also had the good fortune to run into Alpha Stewart. Dr. Alpha Stewart was the president of the American Psychiatric Association at that time, and she's in Memphis, a native Memphian. And she's a community psychiatrist, and her particular interest is juveniles in the justice system. So she was very much an ACE-aware provider. She was sort of my sister from another mother. And I got to do some pretty neat research down at the medical school that absolutely solidified my notions around trauma and ritualized compulsive comfort seeking with substances and processes. So, if that isn't too much of a crazy explanation, that's how, for me, I made the link. And then, the other thing about a physician is if you're just treating the symptoms of a condition, it's never very satisfactory, right? If you can get to the underlying cause of something. So the thing that drives the behaviors around compulsive substance or process, if we treat the underlying process, people have a new tool. They feel empowered. They also start to realize they're not crazy, and what happened to them was absolutely a predictable consequence of the trauma they suffered. And they're so used to being marginalized and otherized by healthcare professionals and just everybody in society, really, that when they meet someone who says, no, I understand why you did this, and I honor the choices you made, even if it became dysfunctional at a certain point, I understand that you were doing this out of a notion of salience, and that you absolutely needed that ritualized compulsive comfort in order to function. And then I say, and I know it doesn't sound like crack use can be a useful thing, right? But the truth is, that's why people use, right? They use so that they don't have to suffer with the terrible consequences of trauma.
And that validation you give them restores their dignity in some sense that, wow, I didn't use because something's wrong with me. I used because something happened to me. And in fact, to quote you, you say, it's not the drug.
That's exactly right.
It's the ACEs. Yeah. So can you explain maybe just briefly to the audience, for those that don't know what ACEs are, can you just explain what ACEs are and why maybe you believe they're at the root of addiction.
Well, I think again, Dr. Folletti in 1998 published the very landmark ACE study out of Kaiser Permanente in Southern California. And Dr. Folletti was a bariatrics doc helping people lose weight. And what he noticed in about 1990 is that patients were on a trajectory to reach their target weights, and they were following the nutrition plans and the activity plans. But inevitably, patients would leave the treatment program before they reached that target weight. And it happened so routinely that he thought, this sort of a Where's Waldo moment, right? Just like looking around the circle. He said, there's got to be something to this. It can't be just a coincidence. So he decided that he would ask 5 of these folks in for a Saturday morning interview to see if he could figure out why they were leaving his clinic early. Vincent and I talked about this. He said, I normally played golf in San Diego on Saturday morning, right? It's San Diego, right? It's 365 sunny. So he said I was a little distracted. When he was interviewing the first woman, he combined 2 questions that all doctors ask all normal women, and that is, when was your last normal period, and are you sexually active? And he asked her, when did you become sexually active? And she said, age 5 with my father. And then he, was sort of taken aback by that. And then without any further prompting, she said, the reason I left your program was that if I was a little overweight, I felt like I was less likely to become a victim of sexual trauma again. I was a little bit camouflaged. And then the next 4 women came in and told almost the identical story. And so again, Vincent said, this can't be a coincidence. He and his nurses began to collect psychological histories and trauma histories on the patients. At the end, they mailed out 25,000 of those ACE questionnaires to patients in the Kaiser Permanente, and almost 18,000 of them were returned. And, if you do a survey, if you get 10% back, you're doing pretty good. But if you get 18,000 out of 25,000, that means that the questions touched a nerve with people. And then Vincent took the results from those surveys, and he was able to show a dose response, linear kind of a relation between childhood trauma and the outcomes like heart disease, cancers, lower respiratory illness, accidental death. By the way, those are 1, 2, 3, and 4 from the CDC of the most common causes of death in the United States. And if you follow that right down through the top 10, it looks like at least 8, and probably all 10 of them have clear links that are dose response links, linear links to the amount of trauma that a child suffered. And linearity in statistics implies some degree of causality. So if we're looking to treat the underlying cause of something and the cause looks like it's trauma, we're not really treating opiate use disorder if we're going to be successful. We're not treating the drug of the day, the drug du jour, right? We're not treating crack. We're treating trauma. So basically, that's how I started thinking about this. And I started doing what I call trauma-informed care. Again, that's pretty straightforward. A lot of times when I go out now and talk someplace, they want to know, how do we implement trauma-informed in our facility? And I have to tell them it's about respect for autonomy for the patient. It's about respect for justice for the patient. And there's a nebulous concept for a lot of people. It's about non-maleficence, which means doing everything you can to avoid harming that patient. And it's about beneficence. And to me, that means it's about doing everything you think of that's a benefit. And it also means not re-traumatizing people, right? Don't beat people over the head with their realities. It means creating a space that feels physically and psychologically safe. So it involves, for sort of the most important thing is a collaborative care plan. So, I don't just start writing prescriptions and say, here, take this, take that, see you in 2 weeks. I say, let's see what you and I can come up with together that might meet your needs right now. And so we collaborate on creating a treatment plan between the client and myself. So really, it's fairly straightforward, and it empowers people. And again, they're so used to being marginalized that they really appreciate being treated with respect.
Yeah, I was just going to say, it must be a whole different shift for them, for the guy in the white coat to actually have him say, what works for you, right? What works for you? How do you want to do this collectively? Yeah, that's a total different way of seeing things. And like you said, it actually empowers the patient to actually know they have a part in their healing journey. So you say we try to meet them individually where they are, understand their needs, and create individualized treatment plans. And then you say it's all about compassion. So that really intrigues me, Dr. Sumrok, that you bring about that essence and that quality of compassion. Can you tell me a little bit more about what you mean when you say it's all about compassion?
The word care itself is from the Latin caritas, and it means love, right? It's also the root of the word charity, right? And that doesn't mean something for free. That means the willingness to give, right? And so when we see people that have suffered marginalization, they've been victims of severe trauma, physical, verbal, sexual abuse kinds of things. It absolutely, and believe me, when they first come, they're very suspicious. Nobody comes in thinking that this is going to work for them. They've all tried to stop using, 15 times at home, and they've said every prayer that they know, and they've done everything they know how to do. So I think compassion means caring. I just don't think it's any more complicated than that. The other thing is, I started this research. I was out in a small town, so it was kind of easy for me to see the impact in a small town when families were reunited, when lives were saved, when people got promotions at work instead of getting fired. Right now in my group, we have 200 clients with opiate use disorder. The average length of stay is just over 8 years, and we have 100% employment. We haven't had a drug-related death in our treatment groups I think we've had around 23,500 encounters with folks with opiate use disorder, and haven't had a single drug-related death since 2000. Since we started this in 2004. So, Freud said, you know how people are doing by how they're doing in their work, their love, and their play. So really, if you keep it to those kind of simple spheres, how are things going at work? How are you and your wife doing? What's happening with you and the kids? Your relationships, and then what do you do with your free time? Because when people come to me and they have opiate use disorder, their free time is spent. Well, there's no such thing as free time. That's spent trying to acquire the medication and using it, and there's no such thing as recreation.
Yes, totally. And as one of my mentors said, the biological opposite of trauma is play, and we can't play when we're driven from those subcortical parts, or fight or flight or shut down, and we don't have access to that ability of creativity, of play. And I think it's so amazing that you emphasize, work and play as part of the healing journey for your patients in the program. And that leads me to, you're the head of the IHC there, the Integrative Health Center. And from reading a little bit about you guys there, you take a trauma-informed approach, that biopsychosocial approach. And why do you believe that taking an integrative approach is necessary for treating addiction?
ASAM says in their on their statement, their mission statement, that addiction is a biopsychosocial and spiritual illness. So again, they're the experts. They're the folks I looked up to when I got into this field. When they say it's about a biological thing, they say it's about a psychological thing, they say it's a social thing, and it's a spiritual thing. I take that to heart, and I look for ways that we can work on those spheres of biopsychosocial and spiritual to give people a sense of independence, and that they can function on their own.
Yeah, absolutely. And I know this to be true from experience. I was diagnosed with ulcerative colitis even after being in recovery for 5 years. My whole colon was ulcerated because I was holding my childhood in my intestine. And until I began to address all the parts of Mike and his life, I never found the healing I was looking for, which required me to do my trauma work, which required me to change the way I ate, which required me to, foster and build safe relationships with people, opening up to love and intimacy. So
somewhere along the line, someone must have said to you, Mike, you're worth it, buddy. We're not grooming you to be a success in the future. We're not trying to turn you into a lawyer or a doctor or a whatever tomorrow. Someone must have said to you, Mike, you're worth saving today, and you have many gifts. And that's sort of the heart of reversing some of that stuff about trauma for people. And that is to help them to understand that they, in fact, are gifts and complex and wonderful just the way they are. Some of the research we did in McKenzie, again, through the University of Tennessee, we followed 100 patients with opiate use disorder over 26 months. And we were looking to try to figure out what we could learn about relapse. And basically, our patients relapsed about as often as anybody else initially. But what we found out is that people were most often likely to relapse in the first visit. We also found that they were more likely to relapse, about a 17% increase in likelihood of relapse, increase of the odds of relapse with each ACE event, right? So if you had one, it was 17%. If you had two, 34%, et cetera, right? So with each ACE event, there was an increased likelihood of you relapsing. But we also found that with each visit to the clinic, with every single visit to the MAT clinic, people showed about a 2% reduction in their likelihood of relapsing. So now, if you just follow that through, that means about 8 or 9 visits, the magnitude of having been physically abused or verbally abused or sexually abused or had someone in your family incarcerated, that was erased after 8 or 9 visits. See what I'm saying?
yeah, and what do you think contribute most to that?
Trust. I trust the patients and they trust me. I'm in a little bit of a Twitter war with an Australian psychologist, and I said to her, my patients tell me what's going to show up on their drug screens, and she said, "Oh, they're drug addicts; they'll lie to you." What I found instead, and of course people will lie, but what I found is that if you don't beat people over the head with their realities, they don't have a reason to lie to you. And so they'll come up to me before group and they'll say, I just drove in from Detroit and I took an Adderall last night. It's going to show up in my urine. I wanted you to know that. Or, whatever it is. So again, I think it's trust. I think that they feel like they're being cared for, right? If that's what, compassion is, I think they feel that compassion.
Yeah, absolutely. And you mentioned another thing earlier in the conversation, which was safety. So safety is so essential to healing, so essential to healing from trauma, especially in like you say, creating that trust. And even though you're a guy who has a lot of letters at the end of his name, they still feel like you're a human being and that they can trust you. And that's really the healing. My mentor, Dr. Paul Epstein, he said, Michael, the healing happens in the relationship. In the relationship of not, I'm the guy in the white coat and better than you, but the relationship of equals. And I think that's really probably a quality that you bring to your patients, and you see the results of building that safety and trust and that relationship with them, which is healing. Trauma is healed in safety, by reconnecting with themselves, with another person, and I think that's really beautiful that you're bringing that quality to the lives of your patients. And I know a lot of people have their thoughts about, medication-assisted treatment and so forth. And I happen to break a $500 a day opiate habit by getting myself some methadone on the street 17 years ago and breaking them up in the little wafers into pieces and taking a piece each day. And I haven't touched an opiate 17 years later. So I know MAT works. And what are some of the results that you've gotten when you prescribe appropriately and work on ACEs and take that other, integrative holistic approach to their recovery and healing and addiction?
Well, again, I think some of those outcomes are things like they're all employed. Their marriages stick together. Many people come and say, almost invariably, people come and say, I got a promotion at work. My boss is starting to like me, whereas we never got along before. That's as simple as them being able to function because they're not distracted by craving all the time. If you're craving, if you're using a short-acting opiate like hydrocodone, which has a 2-hour half-life, you have to dose yourself multiple times during the day. And if you take it at 8 o'clock, by 10:30, it's wearing off, and you need some more. And by the way, if you take 5 at 8 o'clock, you need it again at 10:30 still, because dose doesn't affect half-life of a drug. So those folks are distracted all day long. They make crappy husbands, they make crappy employees, they make crappy brothers and cousins, and when people are able to be relieved of that anxiety of craving, it's a powerful opportunity for them to excel in their lives.
Mm, mm. And you believe that MAT has the ability to help them or create a little bit of space between always having to be leaning forward into that craving, but they can kind of sit back and actually, begin to engage in life again.
Absolutely. Mike, I'd say, one of the things that we have, the reality of addictions care in America right now, is that a lot of it evolved from the 12 steps programs. And in the 12 steps programs, success is abstinence. And I would say that that's not how I look at success in addictions care. I think the opposite of addiction isn't abstinence. The opposite of addiction is engagement with your family, with your community, with your job, with your life. Yeah. By the way, the drug I use most often is buprenorphine, and one of the interesting thing about that is it doesn't make people sleepy or dopey. Right? It's not terribly rewarding, so people don't take it for a buzz. And it has a 31-hour half-life. So you and I might have talked about this before, but at the dental school, we got to do this. At the medical school, we knew that the dentists did a lot of surgical procedures where they used narcotics. And we knew that lots of folks came down to Memphis to the dental school, and they got all their teeth pulled. And so, we were able to see, by the use of a device that, like sort of a Fitbit thing, we were able to track their galvanic skin response and their heart rate variability and their absolute heart rate, their skin temperature. And I could tell when somebody was anxious or craving, but I couldn't tell the difference. So what that means in a practical life is that when people have something happen very early on, when you're using a short-acting opiate, the answer is drug use, right? You couple an anxiety-provoking event with drug use behavior. That's like Pavlov's dog, right? I mean, ring the bell, sprinkle the meat powder. But with a drug like buprenorphine, because of the long half-life, they very quickly uncouple an anxiety-provoking event from drug-taking behavior. And they're kind of shocked at that. They come back at a month or two and they say, something really bad happened. This week, 3 of my patients' spouses developed cancer or were diagnosed with cancer, some of very advanced cancers. All of them got narcotics prescribed by the cancer doc. And all 3 of those patients said, it really surprised me. I wasn't even a bit tempted, even though there was this big bottle of, oxycodone sitting right there on the coffee table.
Wow.
So early on, like I said, when it's a short-acting drug, if you're having a bad day, if you get a big bill, if your kids are acting up, whatever the thing is, that Lortab is the answer, right? That drug-taking behavior is the thing that is conditioned. So pretty quickly, when they lose that conditioning, their lives become much more functional. And I call that walking Ivan's dog backwards, by the way.
That's beautiful. Awesome. Yeah. So they get a chance to, get their life back without that constant craving and leaning forward into the next fix or the next thing. Creating some of that space is really crucial for other, opportunities to open up. And to go back real quick in regards to your comment about 12 steps, and this leads me and can open up another huge door. But, I got sober in 12-step recovery, and then there came a time where, as Bessel van der Kolk says, the body keeps the score, and that all sort of colitis caused me to go inward and really see that there was a lot more going on in here that I needed to take care of than just being abstinent off my drug of choice. So it was that pain yeah, that led me to, wow, I think I'm dealing with unhealed, unprocessed trauma. And really, my message, Dr. Sumrok, for the people who are in recovery, who are still suffering, is, life isn't all about just sitting in church basements and still being driven by, anxiety and depression, but, we can actually heal and thrive and connect in our lives in recovery. And if you're experiencing a lot of those, let's just say, symptoms, then you may still be suffering from unhealed, unprocessed trauma that could be still carried on into your life in recovery. Would you say that could be accurate?
Absolutely. I couldn't agree more. What you said is exactly the way I think about it.
Okay, so for the people that are listening that are already, let's say, in recovery, so quote unquote, they put the drug down, but they're still driven by this hypervigilance. They can't have don't feel safe in relationships. They're suffering from
Right.
anxiety, depression.
Right.
What
Right.
would
So you and
say
I get this, right? In 12 steps, we would say they're white-knuckling it.
Yes, they're white knuckling it. Yeah. What can they do to experience deeper healing? Or like what I say is in the name of this podcast is healing beyond recovery. So what can they do to experience that healing beyond recovery?
Well, I think that there are a lot of things that you can do. Unfortunately, I think organized medicine in this country is just catching up to this. Even though Dr. Folletti did that study and published that in 1998, I think America is just now becoming aware of the power of that study. So I think we have a shortage of guys like you and me that really speak the trauma talk and understand what that means. So I think it's tough for people to pick up the phone and find a trauma therapist or a trauma informed physician. Now, I'll tell you that one of the things that keeps me going is that we're changing that paradigm very rapidly in this country. And not only are we affecting the way addictions care is delivered, but we also think we're changing the way cardiology is being delivered and cancer care and respiratory care, all those other things that I mentioned to you, which were the consequences of trauma. We think that where most doctors are spending their time this morning in the care of heart disease, cancer, and lower respiratory illness and depression, we think that these things we've learned in addiction are generalizable to the larger style of medical practice. We think it gives us a new lens to consider pathology through. And it gives us then new tools to explore about what might help. Unfortunately, I do think it's hard for people to find trauma-informed care. I often give people readings to do so that they can sort of get up to speed. You mentioned Dr. Van der Kolk's book, The Body Keeps the Score. It's one of my favorites, and it's one I often recommend to people. I recommended it to 2 people today. I think, unfortunately, in Western civilization, we've been sort of acculturated to separate the psyche from the soma, and I think American medical care is pretty arrogant about that, and we sort of think that anything from the eyes up is not part of your body, and if you think about it another way, it's sort of hard to say. In fact, your case is a great example. It's hard to say where the brain starts and stops, isn't it? In fact, we know that your gut, like people with ulcerative colitis, your gut is part of your brain.
Yeah.
So it's an unnatural, really, sort of a framework that we've laid for care when we separate the psyche from the soma. And again, I guess that goes back to your question about biopsychosocial and spiritual. We also think about things like, what's your housing like? What kind of job do you have? What do you believe in that's bigger than you? Right? Because I think that's what spirituality is. It's hard at first for people to believe in much of anything because they've, again, been so injured that they haven't had time to explore much. They're very empathetic. Folks like this can spot danger in a heartbeat, and they can spot a friendly face in a heartbeat. So, and that makes my job easier.
Yes. So many good nuggets right there. And it leads me back to, talking about the correlation between disease, right, and adverse childhood experiences, right? The trauma we experience, or if you believe in the disease model of addiction, that what happened to us, right, our biography is linked to our biography, right? The things that happen
Yes.
to us show up in our bodies.
Dr. Tom Price invited me to come to HHS, and I went with Alpha Stewart, that I mentioned earlier, and I didn't care much for Price because he was not a great spokesman for MAT. He told people they were just trading one drug for another, but he asked me exactly the right question, and he sent it to me about a month in advance, so I could take that question to the patients in group therapy and ask it to them, and that's exactly what I did. He asked me the question. He said, what role does trauma-informed play in your clinical decision-making? And so I talked about that with my fellows at the medical school. I talked about that with all the patients in group therapy for a month. One woman said, you tell him, she's very country, and she said, Dr. Sumrok, she said, now you tell him, now I know how I got here, and now you know how I got here. And then she said, oh, and tell him my grandma don't hide the silverware when I come over to visit anymore. Other people said things like the fellows who've been doing, learning to do histories and physicals, they said, just sort of like it was almost an afterthought, like ho hum. They said, well, gee, it's just the complete history, as you called it, the biography, right? So if we can understand what motivates people, what drives people, and that's the purpose of taking a history, then we're much more able to intervene at points where we can be effective with treatments.
And when people understand that what they went through plays a part in how they came to be this way, there's kind of a light bulb that goes on. So for example, I had the privilege of working as a recovery coach in 3 major hospitals in Boston for the opiate epidemic. And I would kind of like come in there and just listen to them, just listen to what they said. And often I just, at the right time, I'd ask them, hey, did you have a difficult childhood? And some of them would just, and I would just listen, and they would tell me the most horrific stories. And then I would just say, yes, and this is why, you're walking around, Boston Public Gardens, homeless because of the pain. Or some of them, I'd ask, do you know why you're using substances? And they would say, no. And I would say, well, you're in pain. And then they would say, oh, yeah. So, linking that biography and biology is sometimes that isn't even conscious to them, but at least holding the space for them to, see that and investigate that, or just be, like you said, just be compassionate with them and just listen is medicine. And when I went to the hospital with universalis ulcerative colitis, do you think the doctor ever looked at me and said, hey, Michael, tell me what happened to you? He never asked that question once, not once. But if I told him my dad was part of the Catholic abuse scandal and my mother was taken away from me at 3 years old, right? Do you think there's a correlation between how I got ulcerative colitis in my childhood? Of course there is. And it's not, and me and you could go back and forth too with, disease, right? You said earlier, the study showed that, most causes of disease are a result of adverse childhood experiences. The organs weep the tears the eyes cannot shed. So what are they holding inside that has manifested? So I think this is a beautiful area of, I know we're kind of bringing up different areas of disease and addiction, but it really just all kind of comes in to one, and at the root of it is the trauma, is the trauma.
Yeah, I would say too that there's a large Venn diagram that includes substance use disorders and the overlapping mental health issues like schizophrenia and bipolar disorder as well. I spoke to a gentleman this morning whose issue was crack. He was severely abused as a child. Someone told him that he had bipolar disorder and began treating him. And what he said to me is the reason that he liked to use crack, because if he had the behaviors that they called bipolar disorder when he wasn't using, he felt like he was crazy. But if he had those behaviors and thoughts while he was using crack, then he was able to attribute that to a drug effect, and he didn't feel like he was crazy. The stigma that we put on people with labels is itself traumatizing. ADHD and major depression and bipolar, borderline, for goodness sakes, yeah. We see lots of people with a borderline label because they've come from these chaotic backgrounds, and their behaviors sound very borderline.
Would you say they're disorders or would you say they're responses?
Well, at some point, at first it's a response. After a while, it becomes disordered, if not a disorder, right? When you're taking 40 Lortabs a day or 50, which is a pretty common amount, you can't get 40 Lortabs a day from a doctor. And very quickly, a thing that was a response can become a disorder that harms you in a biological way, in a psychological way, in a social way, and in a spiritual way.
Mm. Mm. Yeah. Yeah. So it's rather interesting that this kind of all comes together. And you said it earlier about there's a lack of physicians and trauma informed care, and it's really, I feel it's my mission and my passion purpose to really educate the public on the link between ACEs and addiction and ACEs and disease. And, like you say, it is coming full swing around to where, mainstream medicine is becoming more, savvy and more informed about trauma and how it affects the role in addiction, disease, and that sort of thing. And maybe you can just touch a little bit about IHC and tell me, how does IHC's care maybe different from typical just MAT places, or I know you guys aren't a detox, but maybe outpatient facilities. Tell me a little bit about IHC, if you don't mind, for the listeners.
Yeah, so really, we don't do much detox. We're not a detox facility. So people that need a medical detox, they typically go to Vanderbilt or to one of the other institutions close by here. And when they're done with that, they come to Integrative Health Center. I think what's different about us is this trauma lens. I think what's different about us is that we do look at bio, psychosocial, and spiritual, and we don't think that you have to have 4 different doctors to do that. We think it's completely reasonable to train our nurse practitioners, PAs, other physicians to use this trauma-informed lens to understand what they're looking at better. So I think IHC is different in that it's integrative health centers, and that isn't just a trademark for us. It really means that we're attempting to integrate that biological, psychological, social, and spiritual.
Exactly, and I created a holistic recovery wheel that addresses 8 spokes of a wheel: work-life purpose, spirituality, recovery, trauma, as part of the template and backbone for my practice. And I think the integrative approach is so very much needed, and really it's lacking, especially when it comes to, just conventional paths like NA or AA, right? Recovery is just really one spoke of a larger wheel. So I'm really glad that IHC and you are doing the work you're doing, Dr. Sumrok. It's so very important. And before I let you go...
Mike, where are you located? Where's your practice?
So I just moved actually from Boston. I'm in Sedona, Arizona. So I primarily work with clients via online platform, and then sometimes we have in-person immersions. So yeah, I'm based up here in Sedona, Arizona right now.
I did my OB residency down in Phoenix at Good Samaritan. I was going to mention too that I was thinking you were from LA for some reason, but in California, Governor Newsom has appointed Nadine Burke Harris as their first Surgeon General. And Nadine Burke Harris is a pediatrician from San Francisco who is committed and has just gotten, I think, like tens of millions of dollars to implement ACE-informed care throughout the medical system in California. Tennessee has taken a lot of giant steps forward to bring ACEs awareness to the schools, to the correction system, and to the medical system. We just passed a law in Tennessee that says that teachers have to consider the trauma before they discipline a kid at school.
Wow.
And by the way, we know that your ACE score is directly tied to things like truancy rates. Right? We know that your ACE score is directly tied to criminality and recidivism. So again, this ACEs science has bled out of medicine and over into social work. That an article was written about what we do, and it was reprinted in the Journal of Social Work. So it's bled out into social work. It's bled out into education. It's in the justice system and corrections. And again, I think this can't do anything but be good for America.
Oh, absolutely, absolutely. That's like music to my ears. I'm really, really happy to hear all that. ACE is connected to truancy. Of course, it is. It's just common sense. I mean, that's amazing. So, yes, thank you for providing that information with us. And Dr. Sumrok, I just want to thank you.
You say this week.
Mm-hmm.
Yeah, I have a really exciting thing happening right now, and I don't know how this is going to shake out, but SAMHSA, one of the undersecretaries of HHS, called me and hooked me up with the folks from VH1, Viacom, CBS, MTV, and they have a goal of creating a TV series to start next year that will be a population-wide intervention that discusses everything that you and I have just talked about. The role of trauma in addictions and in healthcare and in the justice system, et cetera, education. So, people are becoming aware of this. And, one of the neat things for me is when I wrote that first article, it was published in a medical journal, so hardly anybody saw it. But when this thing was written about us on the ACEs Connection blog, we got almost 2 million views and shares of that thing. And, lots of people saw that. And so it's had we don't typically disseminate medical information on, social media, but this has been a very effective platform to get the word out. And I want to thank you for letting me have a minute to discuss this, with you and your audience.
Yeah, of course. Thank you so much. Yeah, it's so very needed. It's been my journey of really getting to the root, like you talk about, and doing that deeper work and thriving in my life. And it's just my passion and my purpose to really bring that to the audience. And I know, it's yours as a physician to hold the space and treat your patients with this utmost dignity and compassion and care, so they can see the wholeness that they already are. And I think that's so beautiful. So I just want to thank you for coming on the show and taking the time. And before we end, can you just tell the audience where they can maybe learn more about you or your work and your services, or maybe a little bit about where to find IHC, Integrative Health Centers?
So I don't like talking about me too much. The truth is, I think this needs to be about the work. But if you Google my last name, which is Sumrok, a bunch of this stuff comes up. If you Google the phrase, "It's not the drug, it's the trauma," you'll see the article that was written by Jane Stevens from the ACEs Connection blog. And I think that's a very good description in total of this approach. It's not the drug, it's the trauma. Just Google that phrase and it'll come up. And then I'd say, if you're capable of using your own voice, when you see your healthcare provider, challenge them. What do they know about trauma, and challenge them with things like, what role do you think my own personal trauma played in the development of my disease? So
beautiful. It's not the drug, it's the trauma.
That's right. We're not having an opioids epidemic now. We're having an addictions death epidemic that's really driven by trauma.
Absolutely. Thank you so much, Dr. Sumrok. I really appreciate your time, and may you be well.
Thank you, Mike. Thanks very much. Bye-bye.
Bye-bye. What an amazing episode today with Dr. Daniel Sumrok. Thank you so much for tuning into today's show. It was truly a privilege to speak and learn from him and see the importance of taking an integrative approach to your life and recovery. I personally believe if we want to shift from recovery to healing, we must treat the whole person. Recovery is just one spoke of a larger wheel, and by addressing the whole of who we are, by taking an integrative approach, we can experience deeper healing. I have personally created my one-on-one coaching program to do just that, called Healing Beyond Recovery. To learn more about me and my coaching services, please go to my website at www.mikegovoni.com. That's MikeGovoni.com. There you will also find the show notes to the episode and where you can learn more about Dr. Sumrok, his work in the Integrative Health Centers in Nashville, Tennessee, where he is the medical director. I want to thank you so much again for listening, and remember, you can heal no matter what your story may be. Until we meet again, happy healing and be well.